I am Abdullaeva Zarina Abdurashidovna. Our topic for lecture is malignant lung disease in family medicine. So, malignant lung disease, it includes primary, metastatic, and pleural conditions or cancerous lung conditions, and mainly includes non-small cell lung cancer and small cell lung cancer, metastatic tumors, and mesothelioma. If it's about epidemiology, every year we have 2.5 million new cases and 1.8 million deaths per year. Median age for lung cancer, it is 65, 70 years, and survival approximately 80% overall. Risk factors for lung cancer, it is if it's about lifestyle, it is mainly about smoking, secondhand smoke, occupational factors like asbestosis, silica, diesel, environmental factors, radon, air pollution, medical conditions like COPD, fibrosis, prior radiation, and of course genetic factors like family history, EGFR polymorphism. Pathophysiology, it is about prolonged carcinogen exposure like smoking, asbestosis, or chronic lung disease. They lead to the DNA damage. It leads to the accumulation of the mutations and neoplastic transformation. And then angiogenesis and immune invasion, sustained growth, local invasion, and distant metastasis, complete progression. About classification of the lung cancer, mainly we have two types. It is non-small cell lung cancer, which have three another types, and small cell lung cancer. So non-small cell lung cancer divides into three groups. It is adenocarcinoma, squamous cell carcinoma, and large cell carcinoma. Adenocarcinoma, it is most common types of the lung cancer, and origin of it's from the peripheral glands and alveolar epithelial cells, type 2 cells. And most common in non-smokers, it means mainly women and non-smoker men, frequently associated with targetable mutations. Next type of the non-small cell lung cancer, it is squamous cell carcinoma. It is about 20-30% from all lung cancer. Origin of the squamous cell lung cancer, it is from the bronchial epithelium, and squamous cell carcinoma have central location. Adenocarcinoma peripheral location, squamous cell carcinoma central location. Then squamous cell carcinoma strongly linked to smoking and often shows keratinization, intracellular breaches, and cavitation. Next type of the non-small cell lung cancer, it is large cell carcinoma. It is approximately 5-10% of the all lung cancer. And large cell carcinoma may have central or peripheral growths, poorly differentiated, often reclassified as a poorly differentiated adenocarcinoma or squamous on molecular analysis. So next group of the lung cancer, it is small cell lung cancer, which consists approximately 50%. And origin of the small cell lung cancer, it is from the neuroendocrine cells of the bronchial epithelium. It is one of the most dangerous type of the lung cancer because it is extremely aggressive with rapid doubling time and early metastasis. And this cancer also associated with smoking, like squamous cell lung cancer. Here we can see origin of the lung cancer, small cell lung cancer from the neuroendocrine cell, squamous cell carcinoma from the airway basal cells, adenocarcinoma from the type 2 cells, alveolar type 2 cells, and large cell carcinoma from the other epithelial cells. So main clinical symptoms of the lung cancer, it is chronic cough or new cough more than 3 weeks. It is mainly about hemoptysis, about dyspnea, chest pain, hoarseness, unexplained weight loss, fatigue, chest pain, and hoarseness. Here we can see like mechanism of the formation of these symptoms. So symptoms of the lung cancer mainly explained by local tumor growth and tumor secretion of the biologically active substances. So Due to obstruction of the proximal airway, it will be symptoms like cough, fever, dyspnea. Due to obstruction and compression at the local site, it will be symptoms like dyspnea. Due to compression of the laryngeal nerve, it will be hoarseness. Due to compression of the brachial nerve plexus, it will be symptoms like arm, shoulder, and neck pain. Or due to superior vena cava compression, it will be also thighs and arm edema. Due to spread of the tumor to pleural surface, here will be symptoms like chest discomfort and pleural effusion. Due to airway invasion, it will be like hemoptysis. Also, tumor cells, they secrete biologically active substances, and they will be cause of the paraneoplastic syndrome, which is due to growth of the tumor cells. They release hormone-like substances, and these substances will be like cause of these symptoms. For example, due to increase of the adrenocorticotropic hormone, which lead to the increase of the cortisol release and production, we can see Cushing's syndrome symptoms like muscle weakness, hyperglycemia, severe hypokalemia. Due to increase of the antidiuretic hormone, we can see syndrome of the inappropriate antidiuretic hormone secretion. It means increase of the water reabsorption and hyponatremia. Sodium level will be less than 135 milliequivalent per liter. Then, due to increase of the parathyroid hormone proteins, it will be increase of the calcium release from the bones, and on blood we can see hypercalcemia. Due to increase of the transforming growth factor beta-1, we can see increase of the extracellular matrix protein and Finger's clubbing. So, here we can see like a picture of the patient with Cushing syndrome, and diagnostic approach to the patients with lung cancer, step by step. It will maybe 5 steps. Step 1, it is clinical suspicion based on symptoms and risk profile. It means if patient smoker or have some chronic lung conditions, and so cough more than 3 weeks, we have to check them on the step 2. It is chest X-ray or CT of the thorax. Then steps 3, it is about sputum cytology, bronchoscopy, and biopsy. Step 4, it is molecular profiling, and step 5 about TNM staging for management planning. So now about TNM staging. We use TNM staging for assess patient condition. T, it means tumor, size of the tumor. N, it means node, so metastasis to the lymph nodes, and M, it is about distant metastasis. So on the first stage, we have just local tumor without metastasis. Just size of the tumor will be until 3-5 centimeters. Stage 2, here will be increase of the size of the tumor. It may be until 5-7 centimeters, but here also maybe N1, it means like metastasis to the nearby lymph nodes. So stage 3, it means no metastasis or maybe metastasis to the regional lymph nodes, and increasing size of the tumor until T4. Or it may be N2 or N3. It means tumor invaded any of the following. It is pleural, parietal pleura, chest wall, diaphragm, mediastinum, parietal pericardium, heart, medium bronchus, trachea, recurrent laryngeal nerve, vertebral body, or esophagus. On the stage 4, we have distant metastasis at any size of the tumor. So distant metastasis usually will be to the liver, to the bone, brain, adrenal gland, and kidney. So here we can see X-rays of the patients with lung cancer. Like here we can see central and peripheral growth. In this both we can see central growth of the lung cancer. About the diagnosis, we have to do a differential diagnosis of the lung cancer with chronic conditions like COPD, TB, benign nodules, and metastasis. So in COPD, distinguishing features will be chronic cough with sputum and no mass. In tuberculosis, here will be fever, mainly subfebrile fever around 37 Celsius degrees. Here more characteristical like night sweats and positive tests with tuberculin. Benign nodules, here will be like stable on serial imaging. And metastasis, here will be multiple nodules known primary. So management of the lung cancer, it will be different for non-small cell and small cell lung cancer. For small cell lung cancer, if it's like no metastasis, we can do surgery in early stages. Then it is about adjuvant therapy with platinum-based, targeted therapy with EGFR, osimertinib, alectinib, or sotorasib, and immunotherapy with PD-1, PD-L1 inhibitors like pembrolizumab and nivolumab. For small cell lung cancer, we have another management because we're told that small cell lung cancer, it is the most aggressive type of the lung cancer, and here will be rapid metastasis, fast grow and early metastasis. In this cancer, patients comes to us with metastasis, and in these patients usually we start therapy with chemotherapy, immunotherapy, and prophylactic cranial radiation. So screening, about screening. Recommendations for screening, we have to do screening for adults if they are 15 or 80 years old adults. Criteria for them are more than 20 packs per year or smokers. And we can use for them a low-dose CT scan. And our goal from this screening is early detection and reduce mortality. So role of the family physician in this process in malignant lung disease is mainly about early detection, recognize symptoms and risk factors, about coordination, refer for imaging and specialist care, support, it is smoking cessation, psychosocial care, follow-up, manage comorbidities and palliative needs, and communication, deliver difficult news using the SPIKES framework. Palliative care includes dyspnea relief, oxygen low-dose opioids for pain relief, fatigue management, nutrition and psychological support, family counseling, and advanced care planning. For preventive strategies, it is about mainly smoking cessation, radon and asbestosis exposure control, about vaccination with patients who have chronic conditions like COPD, and promote air quality measures. So 5-year survival varies by stages. If it's for stage 1, 70-80%. For stage 4, it will be less than 15%. And this percentage improves with targeted and immune therapies. Thank you for your attention.